Okay, we're going to get started. So my name is Chad Worley, the physician liaison for Lurie Children's, and I cover the city north and west suburban region. And I'd just like to welcome you to our what's now our fourth community provider symposium with the providers and also the practice managers in mind for these symposiums. So you get to learn about our new services, our physicians, what's going on in our outpatient centers, and all the other ongoings and pertinent events when it comes to pediatric healthcare. And I'm joined today by Paula Nowak. She covers the city and south regions, and Julie Kalkbrenner, who covers the west and northwest regions. And we're just so grateful to have you on with us today. And as you see, we posted our pictures for you that we're smiling because it's a gloomy day today. So hopefully we can put a little bit of smile on your face on a gloomy day today. So, but we have a lot to cover today, as you see here on our agenda. And it's going to start with our division head of infectious diseases, Dr. Ravi Jhaveri. He's going to talk to you today about the COVID-19 vaccine for the 5 to 11-year-olds. Julie, Paula, and I will give you some updates about the hospital very quickly, and then we're going to go right into our centralized scheduling updates with our director of Kids Doc, Matthew Ludwig, and then he's going to transition right to that to Dr. Ravi Patel, who's going to do a demonstration of our new MyChart patient appointment scheduling. And I know a lot of you have questions on that and are excited about what's on the ongoings of the new MyChart scheduling. And then after he's done, we're going to have an open forum and chat. You can ask any questions to either Matt or Ravi about what's going on in Kids Doc in the MyChart. And then if you can hang on after that for a minute, as I know it's a busy day for all of you, that we have a few things we would like to share with you from the physician services team. But let's go ahead, and without further ado, I'm going to send it over to Dr. Jhaveri, and he is going to share his screen. So bear with me here, please. You are now our presenter, and I'm going to go ahead and mute myself and take it away.
All right, there we go. Okay. I can't tell. Can you see that now? No?
We sure can. Go ahead and put it in presenter mode if you like, and we can see it better.
Okay, great. I just was making sure. Okay, thanks very much. Welcome, everyone, and thanks. I wanted to just spend a brief moment reviewing some of the data about vaccinating our 5 to 11-year-olds with the Pfizer-BioNTech mRNA vaccine. So objectives are pretty simple. As I said, discuss the results of the phase 2/3 study of mRNA vaccine in 5 to 11-year-olds, highlight some of the safety and efficacy points that are likely to come up as you speak with parents and families about vaccine. And I just want to highlight the source of information that I'm using is the same FDA briefing document that was prepared for the meeting 2 days ago that has got us to this point. So just a couple of points to make about the design of this particular study. So you are all probably familiar by now. The dose that we're going to be using is a 10 microgram dose. This is 1/3 the dose that is used in our adults and children and adolescents. And the way they did this study was they were looking for immunogenicity by comparing antibody levels to those patients, 16 to 25-year-olds, that were given the original 30 microgram dose. And that was in the original phase 2/3 study that was done last year. They did the same thing where they compared safety events seen in the younger children versus those seen in adolescents and young adults. And I want to just also highlight the timing because I think this is a particular point to make with people. So this 5 to 11-year-old study was done during the peak circulation of the Delta variant. And so when we talk about efficacy, especially, it's important to look at that compared to the efficacy data that was generated from the original trials where it was sort of pre-variant original outbreak strains that were done. So first thing to highlight, because safety obviously comes up very early in any conversation, is that the observations in our 5 to 11-year-olds were very similar to what we saw in our adults and adolescents. And actually the dose 1 is the top panel and dose 2 is the bottom panel. And the idea that any complaints were relatively minor in nature and were less frequent in our younger patients compared to our older patients. And it's important to remember, and again, we, as you'd expect, or as many of us experienced, events were slightly more frequent with the second dose compared to the first dose. But it's important that no serious events were observed in this young cohort that were judged to be vaccine related. Okay, so it's really important to stress this in terms of, again, the safety that we've observed that's been consistent across all groups. So how about the actual immunogenicity? So the immunogenicity in terms of measured titers of neutralization, which is that yellow-orange box that I've highlighted for the young kids, was very much in line with the levels that we observed with the higher dose in the older patients. So, so we can say that we're very comfortable with this being the right dose in terms of being able to generate the kind of response that we want. All right, now what about efficacy? This number has certainly been in the news, but when we look at those kids who are vaccinated compared to those who received placebo, the estimated vaccine efficacy was just shy of 91%. And again, I'll make this point that this efficacy data was generated during peak Delta circulation. So again, we feel very confident that vaccine protection is consistent at this point, regardless of what variant we're seeing, okay? And so I would say that this 91% that we saw now is as good as, if not better, perhaps, than the 94.5 that was seen in the initial phase 2-3 studies with the sort of pre-variant circulating strains. So just to highlight this point as well, so if the breakthrough cases that we're seeing in the vaccine group were also really mild, okay? So none of those patients that had been vaccinated even developed a fever. They had a cough and sore throat. And then there were some sporadic complaints of headache, fatigue, nausea, and nasal congestion. Okay, so when you look at that, you're like, well, that doesn't sound any worse than a cold or an RSV as an adult or anything like that. That looks pretty manageable. Those with placebo had many more symptoms and more frequent symptoms and more severe symptoms. And so again, the idea that even if you do break through, if you're vaccinated, your cases are going to be mild. Okay, so there's, again, tangible benefit to getting vaccine. So just to take us home, the bottom lines are safety and immunogenicity with the lower dose of the in the 5 to 11-year-olds was excellent. The few breakthrough cases that we're seeing were very mild. And just highlighting the point that everyone who is eligible should get vaccinated. Okay, so I'm gonna drop out of presenter mode here and I'm gonna stop showing my screen, and I'm happy to take any questions that come up for the next couple of minutes.
Okay, so thank you so much, Dr. Jhaveri. This is great. I know the folks online have a few questions for you. I'm sorry, I was still muted. I'm going to fire away with some questions for you, but thank you for that presentation. Okay, so Dr. Rappaport, she actually sent in a question to me earlier today, and she said she actually has a patient turning 12 in a few weeks. She was planning on having her get vaccinated as soon as she's available. However, is it possible to get the smaller dose at 11 as her first dose and then the full dose for her second dose, since she'll be 12 at the time? So she's not sure how to advise given her change from 11 to 12 dose. And I'm sure that's a question we're going to have.
Yeah, this is a common question that's actually come up, and I would advocate for doing just that. I would, as soon as the lower dose is available, I would do sort of the first dose or priming dose with the lower pediatric dose. And then I think it's fine to follow up with the second dose as the higher dose. I think there are some advantages to doing that versus waiting and doing the 2 higher doses, just in terms of getting the right kind of antibodies and also potentially avoiding a few extra side effects as I alluded to in the safety data.
Okay, that's great.
That's been a common question that's come up quite a bit.
I bet seems like it'd be a very common question. Dr. Bauer, you sent in a question. I just unmuted you or gave you the ability to speak. Do you want to go ahead and just ask Dr. Jhaveri your question? Because you're very good in this forums like this, and I thought maybe you want to fire away.
Jed, can you hear me?
Yeah, I hear you great.
I can hear
Thank
you.
you.
Yeah.
Great. Okay, so I've had parents that are in the know look and say, well, gee, there were only 2,200 or so children in the study, of which only about 70% received the vaccine, the rest placebo. And they're concerned, boy, that's not a lot of children, even though no safety signals arose from those 1,700. And they're saying, I think I'm going to wait a while. What's your best response to that?
So that's a great question. I think it's also one that comes up quite a bit. So I would offer a couple of comments. So certainly there are no vaccine study that we've ever done that can absolutely and positively rule out a rare side effect. So, but what I would say is when you think about our experience with mRNA vaccines thus far and the fact that, you know, now probably all totaled somewhere around 200 million people have received doses, that is a cumulative 50 years of experience. If you averaged the doses we give, let's say, to our birth cohort each year, okay? And when you think about the really strong safety record that we've seen up until now, there's no real reason that we would expect it to be different in our 5 to 11-year-olds. And especially with the data that we have in this small study, again, I think that everything seems to be falling in line. And when we see the antibody levels, again, falling in line with what we've seen in the older patients, I don't think we are going to see differences in this age group. So I think that's the best way to do it. I would really highlight the fact that when we think about our summary experience with these mRNA vaccines, it actually far surpasses what we have with almost any other vaccine we've ever had.
Preaching to the choir, I agree, but I think it is making it a bit of a tough sell when they ask about the numbers. I actually have tried to also point out that Moderna studies, which still haven't been completely peer reviewed yet and will be presented, are I think it's more than double that amount, and we're finding the same safety profile, which is really good so far.
Yeah, I think, again, all of those points, you know, obviously you just have to try to make your best case.
Thank you.
Thanks, Dr. Bauer. Appreciate it. We have a couple more questions, and let me get to those for you. And then they're rolling in. So Dr. Brunner asked, how careful should we be about wasted doses, especially after the initial rush of vaccines?
So I think there's a couple of, so I think wasted dose is obviously going to be a bit of a challenge, but I think the way that this, the pediatric version of vaccine is formulated, it's going to be a little bit different in terms of how it's reconstituted and how many doses are per vial. I've heard other practices talk about how they're going to use a strategy where they're going to perhaps have blocks of patients for vaccine, so they try to minimize some of the wasting. But what I would say, I think, is that we're in a different place in terms of vaccination compared to where we were, let's say, when we started with adults, where we're worried about vaccine scarcity. We're not really going to have that kind of scarcity now. Practices, my understanding is that practices will be able to order sort of smaller allotments of vaccine and be able to manage their supply quite a bit better. And I think all of you will have to make your best judgment about the patients you're seeing and whether this may be the only opportunity you have to vaccinate them. If they're in the office and you've struggled to sort of get to yes, and you don't want to have them leave, I think even if you have to waste, you know, 9 other doses to pop a vial and make sure that this patient gets vaccinated, I would do that. If you know that this patient, this family has been waiting to get it, and they're going to come back, 100 times over to get it, I think you're in a different position as far as trying to schedule. So all of you guys know your patients best, and I would say you could use your judgment about that scenario.
Okay, that's great. Dr. DeJesus asked if boosters will be needed at some point.
I think that's still a TBD, but I would say that when we think about the very, very high antibody levels we are seeing in our young patients, even our young adult patients, and with these kids having levels that meet or exceed those levels, I think we worry about boosters in our older adults, which is why the guidance has been for older adults or immune compromised patients, because their antibody levels don't come anywhere near the levels we see in kids. So we'll see what happens, but I think if and when we need boosters, it's going to be a while away.
Okay, great. I'm going to take 2 more questions, and then if anybody, after these 2 questions, if anybody else has questions, go ahead, put them in the question room, and I'll send them off to Dr. Jhaveri, and we'll send you an email later, okay? But Dr. Christine Janowick asks, is the grace period for the second dose still 17 days post first dose? Any evidence of benefit to longer dosing interval between the doses, waiting 4+ weeks?
So yes, the guidance is still, the dosing interval is the same. I think we've seen evidence for some of the other versions of vaccine in terms of waiting, not these mRNA vaccines, but some of the non-mRNA vaccines. But for now, the guidance is to give the vaccine as it's been studied and as instructed.
Okay, and then the last question from Alexander Downing, can they do it in the legs, or does it have to be in the arm?
I think there's variability in terms of where, it's just been given as intramuscular. I think it's by habit it's been in the arm, but from a scientific standpoint and an immunologic standpoint, there's no difference. So I think whatever is the family or patient's preference, I think it's probably fine. Okay.
Are the side effects similar to this group as it would be for the adults?
In terms of what you would see, yes, but the rates are lower.
Good. Okay, so last thing I'd like you to talk about is what is our position as far as how are we helping with the vaccine of the patients? Are we partnering with some of these practices, or are we doing something through MyChart? Can you explain a little bit how we're going to do it?
Yeah, so I can give a brief overview, and I think that specific guidance will come out once the EUA is officially and the guidance from ACIP officially comes out. So Lurie will, similar to what we've done with other age groups, including the older children's, we will have sort of our vaccine clinics at the main hospital. They'll be, I think, tentatively starting next week. Friday, Saturday, Sunday, and maybe even Thursday also, where patients will be able to schedule and come in and be vaccinated. We are partnering with certain schools in areas to get vaccine, and then many of our partner practices are doing it as well. So I think there are going to be opportunities for, let's say, some of you in smaller practices where the infrastructure may be significant to try to do vaccine, that you'll be able to find access for your patients. I think, in my mind, I think one of the considerations is just how much sort of commercial pharmacies will do the younger kids. My guess is that some will have the infrastructure to do it, and then some patients will be more or less comfortable getting it in those settings. But I think there will be many options, and you'll have to know that sort of Lurie home base will have some, and then just knowing what's available to you close to your practice.
Okay, thank you for that. And for those of you listening, your physician liaisons will send that information over to you once it's everything, all the T's are crossed, I's are dotted, right? We'll send that over to you, but we don't want to send anything to you until everything is signed, sealed, and delivered. So, yeah. Dr. Jhaveri, thank you so much. Really appreciate it. And if there's anything else, we'll just go ahead and let you go.
All right. Thank you. Good luck, everybody.
Thank you. Yeah, take care.
Bye-bye.
Bye-bye.
Okay.
Okay. Julie, I'll share my screen in a second here and we'll get you going.
Great.
So bear with me, everybody.
Sure.
It's been a few months that we did. It's been a few months since we've done these, right, folks? So I got to get it back going.
Yeah.
So anyway, so this was Dr. Jhaveri. I was supposed to show this slide. Sorry, everybody. Okay, Julie, take it away. Julie Kalkbrenner here is going to go over our new specialists for you.
All right. Good afternoon, everyone. I just want to introduce a few of our specialists to you who have joined Lurie medical staff and will be seeing patients either at Lurie or one of our satellites, and they have just started in the fall. So we have 3 new cardiologists. Dr. Brian Madden has joined us, and he will be working with CV surgery and transplant surgery, and he'll be seeing patients at Skokie, Lincoln Park, and Arlington Heights, in addition to the main hospital. And next we have Dr. Wolf. He also is in cardiology. He's just going to be seeing general cardiology and single ventricle patients. And he will be seeing patients at Arlington Heights, Skokie, and Grays Lake. And our 3rd cardiologist is also a fetal cardiologist, Dr. Joyce Wu, and she'll be seeing patients at CDH within the MFM clinic, and then also Skokie. GI has added a new provider, Dr. Maria Perez, and she works with functional GI disorders and inflammatory bowel disease. She will be seeing patients at Lurie, Lincoln Park, Skokie, and Lake Forest. We are happy to welcome back Dr. Ellen Kim with endocrinology. So she'll be treating general endocrine disorders and will be seeing patients at the main hospital. Dr. Janaki Pescara-Devan is one of our new pulmonologists, and she is going to be seeing patients at Lurie, Lincoln Park, and then also at Central DuPage. Her interests include chronic cough, high-risk asthma, and she'll also be working in the multidisciplinary MDA clinic. We have 4 new neurologists introduced to you as well. Dr. Riga Purwit and Dr. Laura Vernon will both be seeing general neurology and epilepsy patients at Lurie. Dr. Talia Shearer is another general neurologist, and she'll be seeing patients exclusively at Central DuPage and Delnor. And Dr. Jeremy Wong will be seeing epilepsy patients at Lurie and Lincoln Park. And any appointment for these providers can be made through KidStock or the Lurie MyChart.
Thank you so much, Julie. Appreciate that. Okay, I'd like to hand it over to Paula Nowak, who's going to talk to you a little bit about our 10-4 FACES program. Paula, take it away.
Yes, this month, Governor Pritzker declared October 4th to be a day to be aware and to combat child abuse. And so he recognized the tool that you see in front of you, which was developed by Dr. Mary Clyde Pierce, who's an emergency room physician at Lurie, and her colleagues. And it really recognizes bruising as the most common visible sign of physical abuse. And this tool helps differentiate between what is normal childhood accidental injury and abuse injuries for children 4 years and younger. So by looking at any of the 3 components, regions, ages, and patterns, you can distinguish between what's accidental and what is abusive. So the 10 is the acronym for torso, ears, and neck, faces, frenulum, angle of the jaw, cheeks, eyelids, and subjunctiva. And then if looking at ages, any bruise anywhere for an infant 4 months or younger. And then patterns, looking for slapping, grabbing, loop marks. All of these can help distinguish any one of these. And you would want to refer for someone with expertise in child abuse. These tools and other resources are available on our website, either through the QR code or your physician liaison can provide them for you. And moving along from that, we want to get to our main speakers for the day. Lurie's made significant strides in terms of centralized scheduling through KidStock, and also in scheduling through our digital front door. And so today we'd like to welcome Matt Ludwig, who's our director of the Centralized Access Center, known to you as KidsDoc, and Dr. Ravi Patel, our VP of Digital Health. So take it away, Matt.
Matt, I'm going to unmute you. I'm sorry, I'm scrolling through trying to find your profile here, so please bear with me. You're good to go, bud.
Hi, can everyone hear me?
Yeah, we hear you great. Thank you.
Perfect. All right. Sorry for the technical difficulties here. Hello, everyone. My name is Matt Ludwig. I'm the director in the Centralized Access Center. Dr. Ravi Patel will also be joining me, and I'll be handing it over to him in a moment. I'm wondering, can everyone see my screen right now as well?
We can, but it'd be great if you could put it in presenter mode.
Absolutely. And actually, I'm going to be handing it off over to Dr. Patel here shortly. So let me put it in, well, let me see. That probably makes it even more difficult to see. I will simply zoom in here for the moment, and then I'm going to hand it over to Dr. Patel so he can do a demo of our MyChart and make sure everyone is able to see our functionality. I really want to give an introduction and update over here in the Centralized Access Center, also referred to KidsDoc. And then Chad, I'm just going to ask that you grant presenter access to the Matt Ludwig that is being viewed as a presenter itself, not the guest version. So again, sorry for the technical difficulties here, and thank you all for bearing with us. So hello, as I've already stated, I'm the director over here in the CAC. Again, that's if you call 1-800-KIDS-DOC and select the scheduling option, that's how you'll get to us. But really, I'm here to give an overview and an update of what's changed over the last year, and then highlight some of our new digital initiatives when I'll hand it over to Dr. Patel. So what we wanted to go through here are some of the changes, and obviously being a call center, if you will, we do have the ability to present a fair amount of data to highlight what exactly is taking place. So at the top left here, what you can see is our call volume. That's purely inbound volume. Hi, Ravi. As well as the what we call one call resolution. So a major initiative that's been taking place over the course of the last 12 months or so is ensuring that parents who call in get to the right individual who can assist them as soon as possible. When we first started measuring this back in September, it was happening about 58% of the time. So what we're saying there is that effectively 42% of the time that a parent would call in, they would be guaranteed to be transferred. So that obviously doubles the time that they need to wait, get to the person that's the most successful and able to help them immediately, or translate that over to the division that will be able to assist them further. So that's effectively a guarantee that they'll be handed off. As you can see, that green line up at the top left has now increased about 25% or so to 82% of the time. So that's getting to the right individual in the Centralized Access Center that is able to assist you to the best of their abilities through the decision tree process that's been implemented. So this was a huge initiative that we wanted to make the focal point of the last fiscal year, and something that we are able to track and trend to ensure that these parents and families are receiving the best customer service and care that they deserve here in the CAC. We also always trend our abandonment rate. So in the graph at the top left, you can see the purple line. It may be a little bit difficult to see, but here effectively you can see a drop from roughly 20% to 11%. That's still not where we want to be as a department. Our goal here is 5%, and we really, what I keenly keep track of is our average speed to answer. To me, that's a factor of abandonment rate, and that's what drives that metric. So this graph here is meant to represent how long a parent or family would actually wait. So we are seeing improvement, but we want to see even more. So our goal is to have 80% answered within 30 seconds over the course of the next fiscal year. Continuing to build up our staff and infrastructure is the focus now that we have the system in place to assist those parents and families. One thing that I did want to highlight in all of these metrics, you see these what I'll call spikes right here after the yellow bar. The inbound volume here was actually somewhat of an anomaly for those. I know we just discussed a little bit of COVID, but for those that do recall, this was actually when those numbers were starting to decline, and we saw a significant influx in not only ambulatory volumes, but as a factor, inbound call volumes. This happened to be the same time that we were completely reconverting and upending a workflow that was transferring. Originally, scheduling would take place and then registration. Now we register the parents as their schedule. That way they don't have another guaranteed handoff. So the overall workflow has changed dramatically over the course of the last year, with the focal point being patient and parent satisfaction. Now we are able to optimize everything that's been built over the course of the last year to improve that average speed to answer, which will, and by proxy, reduce the abandonment rate, getting that call to the right person at the right time to get them scheduled at the right place at the right time. The other thing that I wanted to highlight, which has also been a factor in our coverage ability, is that the centralized access center is now scheduling more new patient appointments than ever before. So this bottom left graph here is actually representative of exactly how many new patients are scheduled here in this department. You can see that even when the inbound call volume back in September was significantly high, really as high as it had been at any point in the fiscal year, we scheduled about half as many patients at that time. So now there are less handoffs, more ability to schedule and get those parents scheduled, those patients scheduled when they call into the centralized access center. And at the moment that we're fully staffed, we'll continue to see improved customer service, as well as an improvement in that average speed to answer. The last thing that I'll point out on this graph, because I know it's a very busy one and I want to hand it off to Ravi as soon as possible, is that this is a representative graph of the functionality that we now have in terms of percent capability to schedule, both for decision trees in KidStock, which I call the centralized access center, as well as on MyChart, so self-scheduling. As you can see, we're at a point that these two are about to meet, which is really exciting. We utilize the same platforms for scheduling and algorithms as MyChart here in the CAC. So with that, I'll give one quick overview of what took place with this change to one call resolution, and then I'm going to hand it over to Ravi and ask that he be granted presenter access so that he can give a demo. But effectively, as I outlined earlier, the initial concept here in the centralized access center was for parents to call in, be triaged by our mainline representatives, be sent to the centralized access representative at the time, if they could schedule or determine whether they needed to be escalated to a nurse. And then the nurse would determine if they needed to go to the division or not. And then if they were scheduled by a division, they would then go to our registration department to be registered. Now the new concept is for the parents to call in, select their surgical or medical option, and then be triaged directly to the patient access specialist, who will be able to schedule that appointment, or triage to the division when necessary, which the goal would be 20% of those patients would be sent to the division. So that's the new process. And again, registration takes place at the point of scheduling now, as opposed to that transfer being required, which was a significant process that took place back in April. So I'll pause. I know it's probably not time for questions yet, and we want to make sure that we can do that, but I want to hand it over to Ravi to make sure that he has a little bit of time to go through everything that he's been doing this year as well.
Yeah, I just made you a presenter, but real quick, I'm jumping in here. There's some questions coming in. Folks, I just want you to know, go ahead and put your questions in, and then when Dr. Patel is done with his presentation, we'll go ahead and do a Q&A afterwards, where you can ask either Matt or Dr. Patel your questions on access. Thank you so much, and Dr. Patel, please take it away. All you have to do is unmute yourself. Go ahead. You're ready.
Can you guys hear me? All right.
Yeah, you're ready to roll.
Excellent. Can you guys see my screen as well?
We can see the Lurie Specialists
Website. Perfect. Okay, so I'll just quickly go through. I wanted to do a MyChart demo. I'm going to go through some quick slides for everyone to give some context of where you would go to, depending on if you're a new patient to Lurie Children's versus if you're an existing patient. So for patients that are new to Lurie Children's, you could actually just go to our website and you should direct our patient or any patients that need a referral to any specialty here at Lurie. They can then actually now schedule effectively online or through a request process. And so if they just go to our homepage, click on make an appointment, they will be taken to this appointment scheduling request form. So there's a lot on here. I'm going to quickly walk everyone through in live fashion how this would actually work. So if you click on make an appointment, any patient can then choose to do this online. They have the option of scheduling through MyChart, which we'll come to in a second, as well as through an online scheduling form. We're assuming that most of your patients have never actually been seen at Lurie. When you're making the referral, this is their first time they're coming here. So this is where an online scheduling form is critical. If they've ever been seen by anyone here at Lurie, they can actually just go into their own MyChart, which we'll also demonstrate as an opportunity to schedule an appointment. Both of those options are available to all patients at the end of the day. And so I'll actually show you in real time how this would work. So if I click on online scheduling form, it'll bring me to our portal where we can actually then schedule appointments. I'm actually going to walk everyone through what we would do for immediate care, which is true open scheduling, completely online and available. When you click on immediate care, it'll ask you whether or not the patient has any sort of emergency or life-threatening condition, and they verify they don't. And then they also recognize that we don't take care of these issues. They can then put in their date of birth, and choose their appropriate insurance plan. And based off of that, so independent of what I choose, if I choose Medicaid, it'll then let them actually pick a time and date to schedule an appointment for an urgent care visit. And so this is all for immediate care. For patients who are coming here for a specialty referral, they would actually click on all other appointment requests and then hit next. And I'm actually going to flip to a new page where I've already filled this out. So when they get to the appointment request form, patients can then just fill out their information, fill out their child's information, their referring provider, their address, and then they can actually choose a specialty where they want to make an appointment. And so in this case, if they decide they want an appointment with rheumatology due to joint pain, they can then hit submit appointment request. You'll see here at the bottom that they will get a notification whenever they choose rheumatology that the specialty you've chosen actually allows you to make an appointment on MyChart. So within one business day, this patient will actually get a MyChart account link to instantly activate for a MyChart account. And based off of that, they will actually be able to schedule an appointment. Notably, if the patient already has a MyChart account because they've been seen at Lurie before, or they have a Community Connect MyChart account, they can actually then just log into their MyChart account. Before I go forward with that, I will actually show everyone how you actually create your own MyChart account. So for patients who have ever been seen here at Lurie, they can go to our MyChart website. To get there, just from our homepage, they can click on MyChart at the top. Click on MyChart at the top, and it'll take them to our MyChart homepage. From their MyChart homepage, this first button is available for all patients under the age of 12 or 18 and older. To be able to get a MyChart account, and any patient over the age of 12 will need authorization form signed, and so they would click on this second link. So they would then be able to actually fill out their entire authorization form. So if they're less than 12 or 18 or older, this is the window they would see. They'd fill out their information, they'd get the verification, and then they'll get an email that'll actually send them an instant activation code. They just click on the link, verify their zip code and date of birth, and based off of that, they can then create a username and password and log into their MyChart. For patients that are between 12 and 17, we do need an authorization form signed. And so this authorization form now is fully digital. They can actually just go to the web page, fill everything out, and I will show you all in real time. It's hard to fit it all on a slide. But after they fill out their information and they read through the consent, they can actually just sign this form right here. It doesn't require any faxing of information, and you can then hit submit form. So both of those pathways will allow a patient to get fully signed up on MyChart. Now I'm going to log into our live environment. I'm actually going to just log into my son's account to show everyone what it would look like to actually schedule an appointment. So when they log in, they'll switch to their actual child's account, because every adult is granted proxy access to their child. When they flip over to the child, they'll hit schedule an appointment, which should be at the top bar for every patient. And when they click that, on the right-hand side, they will see all of the specialties that are available for online scheduling. And so Paula had reviewed this a little earlier. These are all of our specialties that are available for self-scheduling. I'll actually walk everyone through an example here. So if I choose rheumatology, just as I was putting in the appointment request form, I want to be seen for joint pain. I choose rheumatology. I recognize I haven't been seen by another pediatric rheumatologist. My issue is joint pain and joint swelling. There's not really any swelling there. There's no weight loss, and there's no muscle pain, chronic fevers, rash, eye concerns, or skin color changes. And so after you do that, it'll actually give you a notification that will then take you straight to scheduling as it searches the system for appointments. You can choose any of the locations that are appropriate for that provider. And so let's say we live in Lincoln Park, so I'm willing to be seen at our main campus or Lincoln Park locations. I'll hit continue. I haven't been referred to any specific provider in particular, so I can select all of the providers. And then you can see that the first available appointment is in 3 weeks, and you can actually schedule an appointment straight from here for that patient. They can just enter in whatever is most important to them and just hit schedule. For patients who don't have insurance information on file, they'll actually be asked to then put in that insurance information and then go forward into scheduling. So flip back over to the PowerPoint. So this is all of what we walked through, and we're happy to send these slides out for everyone's reference. But once you log in, you'll just click on schedule an appointment. You see all the divisions that are out there for scheduling, and then you can actually pick a date and time. So this last fiscal year has been a eventful one, to say the least. We've been working on a lot of different digital strategies for patient engagement across our digital front door, around access. A lot of the work that we've been doing is around what we just showed you, is how do we make it easier for a patient to get a MyChart account? How do we get them activated on a MyChart account? How do we get them using it to be able to schedule an appointment? So that's a lot of what we went through with the MyChart activation and decision trees. I also want to highlight some of the other functionality, which we'll talk through in a second, around open scheduling and some of the asynchronous e-visits that are out there. And then we've also been focused on building out our telemedicine platform. So we were previously in an unintegrated telehealth solution. We're in the process of going to Epic Video Client. That'll be an integrated video solution that'll hopefully help us grow capacity and grow availability, which will then also expand the reach of where our patients can be seen. Same thing with providers. Some of the provider efficiency solutions, we've been looking at how can we actually better engage our patients earlier on to collect the right information, and then actually leverage that information to then generate the right assessment and plan more quickly, so that all of these notes can be sent back to the referring providers in a timely fashion, and making sure that everyone is in the loop of the information that's out there. And then the last piece is around remote patient monitoring. We've been building out a longitudinal solution. We're testing this, we're piloting this within the next month around post-operative scenarios and perioperative scenarios for tonsillectomy adenoidectomy, which essentially guides a patient from when it's decided that they need a tonsillectomy adenoidectomy all the way through the time of their surgery, and then post-operatively helping to monitor and then prevent any unnecessary readmissions by better controlling pain, identifying issues earlier on, and then escalating issues appropriately. In terms of open scheduling, we went live with this on June 28th. So this is what I was showing earlier for immediate care, urgent care scheduling. And you can see the lighter colors here represent patients that have been scheduled through kind of our open scheduling platforms. You can see we had a pretty nice steady growth, and some of this was just kind of environmental and situational, and that's our open scheduling has been taken up by patients pretty robustly. Most of our appointments are, by the end of the day, not available. And so as with your help, we've been making referrals for patients after hours that need any sort of immediate care. They've been able to then just go to our website and schedule an appointment on their own. In parallel, we've also released asynchronous MyChart messaging. So these are e-visits. So patients who have been seen by our specialties before have the opportunity to actually have a secondary evaluation purely by MyChart messaging. So I'll take the same example, continue on with the rheumatology example. Patient has joint pain, was seen by a rheumatologist, was recommended to proceed with physical therapy. 6 weeks goes by, has gone through physical therapy. At that point in time, they can either come back for a return visit, or they can continue some of the messaging and share back and forth some pictures of what their joint looks like, what their exam looks like, etc. with those messages back and forth, they can actually turn that into a billable encounter, but also make it a lot easier for a patient to then get the care they need where appropriate. Now, this will only be in scenarios where it's a straightforward problem, doesn't really require a physical exam, and you've got a reliable caregiver or the use of MyChart photo. In cases where we do need a physical exam, our recommendation is that still in person, and we still have that opportunity, and that's where the self-scheduling piece comes in. The last piece I'd like to highlight is Lurie Children's Care Now that went live just over a month ago. And this is an opportunity where we do realize some of our specialties have really long wait times. And what we want to do is be able to get those patients in as quickly as possible, but at least get some of their testing started once they get in. And so what we've done is we've started a program where for genetics, we launched it for GI, we're about to launch it for developmental and behavioral pediatrics, and then thereafter we'll launch it for genetics. In all three of these cases, the whole idea is that the patient can be seen in a quick time period, usually within 1 to 2 weeks. They can schedule this whole appointment online, and after scheduling their appointment, we can actually get some of the process started. So any testing that needs to occur can occur, any other further evaluation that's necessary can occur. And then at that point in time, they have their specialty visit, which should also be scheduled at the same time. And so that specialty visit, now you can go in with all that testing that you need to then make the evaluation quicker and preferably more expedient. And I'm not going to walk through all this, but these are all the things of what's in store for the next fiscal year. But I'll leave the time for questions and discussion.
That's great. That's great. Thank you so much for that presentation. I'm going to go ahead and send it over to Paula. She has a number of questions that she wants to field to you guys.
Yeah, no, a lot of the questions are related to the request for service. I think there are some questions wondering is it still necessary for a physician to put in a request for service and to allow the patient to make an appointment through MyChart?
So they don't need to put in a request for service for a patient to make an appointment through MyChart. The reasoning that it's important to have the request for service in, though, is that patients who are on HMOs or other insurances that require referrals prior to their visit, we still need that request for service, because that request for service serves as that referral for us to then make sure that we're actually getting compensated for those specialty visits. So our request is that you still submit the RFS either through Epic or Epic Care Link, but you don't necessarily need to then follow up from it, because the patient can then still schedule their appointment, and they can happen in parallel. So while the patient is sitting right in front of you, if they want to log into MyChart and schedule their appointment and you put in the RFS later, that's totally fine as well. We just need the RFS in the system prior to the patient arriving.
Okay, yeah, because that was another question. Our request for service orders still being addressed. So clearly they're still being addressed from everything that you're saying.
Absolutely. Every RFS that comes in, I'll let Matt talk about that.
Yeah, so it's in some sense, a little bit duplicative. Ravi highlighted the importance of submitting the RFS, but it does not bar anyone from scheduling on MyChart. Also, these are on the back end actually converted to appointment requests now, which is a little bit more into the weeds and the detail of it after we start up on decision trees. But effectively, we will just link it if they've already scheduled their appointment on MyChart if it isn't already. So the RFS are still worked actively, and there's no reason not to, but it's not a necessity any longer.
Okay.
For decision trees. For those that you can
We have
schedule.
another question. I can see that there will be referrals to either the wrong specialist or may not even need a specialist. This seems counter to a primary care gatekeeper, meaning the pediatric provider.
So that's actually one of the pieces here, is that it'll actually ask for a referral, whether or not a referral has been made. It's usually the first question for that tree. I skipped through it really quickly because I had previously answered that question. But if there is a referral already there, then it won't ask that question. If the referral is not there, it'll actually ask to make sure that the patient does have a referral from their primary care provider to schedule an appointment. And then as you saw on the appointment scheduling request form online, so if you're just submitting a request form, if a patient is submitting the request form, it'll ask for the referring provider to make sure that that care is actually necessary. And then the last piece is as we went through the questions for rheumatology, every division that is available for self-scheduling actually goes through very similar questions. And so if patients don't have any of those symptoms, don't align with what is seen in that specialty, they actually fall to a work queue to make sure that that patient actually needs to be seen prior to then being scheduled for an appointment.
So I think pediatricians are hearing loud and clear that information from them through request for service and other means is extremely important to us.
Yeah.
Okay. I think that handles all the questions in the question box. Again, if people have more questions, you can type them in and we'll be glad to send the answers out from Matt and Dr. Patel by email. Oh, it says one more thing. Is there a way to catch people who might need more urgent care?
Correct.
You can submit
Yes.
the RFS as urgent. Yep.
So not only can the RFS be submitted as urgent and then make sure that they're getting in as quickly as possible, but the decision trees actually actively do that just as well. So that not only do our goal in the decision trees is also to identify patients that need to be seen emergently. So patients who, for example, I didn't go down the headache tree, but present themselves as having the worst headache of their life and also having neurologic deficits, focal neurologic deficits, that being extremely concerning, we actually stop them right there and have them either call our centralized access center to talk to a nurse to be sent to the emergency room or pointed back to their pediatrician to make sure that they don't need to go to the emergency room before that they can even proceed. We're not going to let them go down an entire tree and then schedule an appointment 2.5 weeks from now. That's just not safe at the end of the day. And so this then catches those scenarios where we can then bucket them into emergent, urgent, so the ones that need to be seen within 2 weeks and they actually get a notification saying, please make sure you schedule within 2 weeks, or things that are more routine and can then just be seen as next available.
Okay. And then more of a comment than a question, and it's that it would be appreciated that Community Connect practices not receive requests for records when it's available in Epic. So kind of a reminder to us.
Yeah, we can definitely convey that message. We're actually meeting with all of the divisions on Tuesday and Wednesday, so we can make sure that that message gets communicated. And we have our ambulatory leadership committee later today, so we'll make sure it gets highlighted there as well.
Great. Well, thank you so much. And I'll turn it back over to Chad to wrap it up.
Yeah, Paula, thank you. And Ravi and Matt, this was an awesome presentation, and I'm sure the folks online really appreciate what you guys did here. So thank you so much. And if anybody has questions for them moving forward, just please reach out to your liaison and we can help you with that. But we're going to finish up here really quick here. Just a few notes from the liaison team that save the date. We are bringing back our virtual roundtables that were so much of a hit last year and in the early summer. So we, as you see here, we're going to have on November 11th, we're going to have an epilepsy surgery roundtable with epilepsy. Topics include epilepsy, infantile spasms, EEGs, when to order, how to explain results to families, dietary therapies, epilepsy surgeries and devices. And then Wednesday, December 8th, we're bringing in the special infectious disease team, talking about urinary tract infections, common ID calls for the nursery or common HSV questions for mom and baby, HIV, trends in staph resistance, and Kawasaki topics. So great stuff. And then, of course, spring 22, we'll be having coding for you. Julie will talk to you about that. And just real quick, I know November 11th is coming up, so you'll be getting an invitation to join that meeting shortly. So look for that. Julie, do you have anything you want to say about the coding event?
Sure. I just wanted to let everybody know that we will continue having our coding education conference this spring. It will most likely be in March. Sadly, Dr. Tuck and Danelle Holly have both retired from the speaking and educating on pediatric coding. So we have two new speakers this year. Both of them will be physicians, and they will be covering similar topics as Danelle and Dr. Tuck. did, updates for CPD, ICD-10, and E&M codes, as well as the modern pediatric encounters that include telehealth, mental health, and COVID. So more details to come, and we will look forward to sharing that news with you probably early January. Thank you.
That's great. Thank you, Julie. So I also want to remind you to be on the lookout for our community provider communications that we send out to you once a month. This is really important information since we're not in your offices yet for the most part, and bringing you the updated outpatient center schedules. As you can see here on your left, the outpatient center news provides that for you. You're able to download that when you need them. And then each month we'll be providing you with updates of what's going on with Lurie Children's and other matters in pediatric healthcare. So please read them. We only put in information that we feel that's really important to you in your practice. And then I encourage you to share it with your colleagues as well. So I hope you're enjoying them. And based on our feedback, it seems like you are. Speaking of feedback, we listened, we heard, we listened, and we reacted. You guys wanted a centralized space where you can access all the information that we provide you. So Physician Services now has a homepage. So go to luriechildrens.org/physician services. There you will see, you can download the referral guide, the phone numbers, the locations. You can view our videos that we had in roundtables and symposiums. All the information that you could possibly need, it's going to be right there at your fingertips and then some. All you have to do is click on it, download it, print it if you want to. As always, we'll bring you more. And if you would like us to come into your office and bring you some additional booklets, please send us a note. We'd love to see your faces. We'd love to be in. So just let us know when you come in and we can bring those to you, okay? And then last but not least, we want to let you know that we are social. So please, if you are on social media, follow us. We have a lot of information that we not only put out ourselves, we like to introduce our new physicians on social media, but we also repurpose other stuff that's coming out through the hospital that you wouldn't normally necessarily see. And you'll also see the button there that says YouTube. We encourage you to subscribe to our YouTube page for Physician Services. There you will see the symposiums like this one that you'll be able to view, and all of our roundtable discussions. Some of our roundtable discussions have over 400 views on them. So we see that you guys like them. So I encourage you to go on there. And if you have any suggestions, please let us know. But that concludes our session for today. Like I said, we look forward to seeing you. Please let us know when we're able to come back into the offices and visit you. And if anybody has any questions, put them in the question room. Otherwise, we will see you soon. And please be on the lookout for the link from today's meeting. And that's that. Have a great day and great to see you all. Bye-bye.